Good morning and welcome to the sixth live case webcast of peripheral and endovascular cases. I'm George Dangas from Mount Sinai Medical Center. I would like to welcome you once again at the www.peripheralvascularinterventions.org that not only hosts today's webcast but also archives all past webcasts that we have done. Just to let everyone know, it's very exciting to have completed the 15th annual Symposium of Complex Coronary and Vascular Cases. Just 2 weeks ago is our annual symposium, live symposium here at Mount Sinai. We had 23 coronary cases and 8 vascular cases transmitted live from our cath lab to the main auditorium with the staggering participation and attendance this year. Regarding the peripheralvascularinterventions.org website, I'd like to let you know of 2 things. There is a new educational video uploaded by Dr. Jose Wiley with a discussion on the approach to severe superficial femoral artery claudication and calcification. Today's webcast comes to us with support from EV3. And also, I want to remind everyone that the next webcast is going to be on July 25th at the same time exactly, no matter where you are. I know we have tremendous, not only national, but also international attendance to this webcast. Therefore, same time, July 25th will be the next and 7th live case webcast. So without further delay, let me introduce you to the cath lab team. Dr. Krishnan and Dr. Wiley, good morning to both of you.
Good morning, Dr. Dangas. Good morning. I'd like to introduce our team in the cath lab. Dr. Dangas has been kind enough to introduce us. I'd like to introduce Ray Lascano, a nurse practitioner, Dr. Ziad Ali, our outstanding interventional fellow, Paul, our nurse, and Ricky, our technician. And we've been kind enough to help us get this case ready very quickly to be started at 8 o'clock. I'm going to ask Dr. Wiley to present the case and then go over the angiographic findings. Dr. Wiley?
Yes.
Slide, please.
Please slide.
There you go.
Yes, good morning, everyone. This case for today is a 67-year-old lady with a past medical history of hypertension, hyperlipidemia, coronary artery disease, status post percutaneous coronary intervention done in the past, pending a stage PCI of the circumflex artery, who comes for elective percutaneous intervention of a symptomatic 80% left internal carotid artery disease. She actually had a TIA 4 months ago. It's actually an ipsilateral TIA to the artery that is affected. Let's go through the anatomy. We have some pictures done
Just one, Jose, would you give us a glimpse of the medical therapy the patient has been on and the cardiac symptoms as well? Yep. Because I see it had PCI and you know there's another PCI and all that.
Absolutely.
Yeah. This patient, in terms of the medication, she's on aspirin, she's on beta blockers, she's on an ACE inhibitor, and she's also on a statin. She had a prior LAD intervention. She had a circ lesion, which is actually being staged for further intervention.
Now, as far as statin therapy, she is on Lipitor. She's my patient, so her LDL cholesterol is under guidelines, doing really well with that. You know, it was very surprising. She was asymptomatic, George, and we had been following her for a while, just asymptomatically. And between the first stent and the second stent, which was staged, she went ahead and had this TIA, where she had right-sided symptoms, classic, looked like middle cerebral artery territory. So we've gone ahead, and what we did was we got an outpatient workup. And what we normally do here at Sinai, as you know, we do ultrasounds here with Dr. Olin's lab. And we found very, very high peak systolic velocities in this particular lesion. The peak systolic velocity in this particular lesion was around 335 with an early diastolic velocity of around 147. So also the plaque was very complex. Now, this lady had a stent because of unstable syndrome. Just about 6 months ago, had a TIA, has been followed closely. We've got neurology involved, everybody involved. And basically, her EF is low. Her EF is around 35%. So it makes her a high risk for, along with the known coronary disease, makes her a high risk for carotid endarterectomy. Now we work very closely, as you know, with our surgical team, and everybody's involved, and everybody feels that this is a good patient who will undergo, who will be a good candidate for percutaneous intervention of this carotid. Now, other things, interestingly, is that we have got obviously CMS indication here for this particular lesion. So we're going ahead and we're actually billing this, the usual way that everybody at this current stage. She's not in part of any protocol or anything like that. The second thing about her, very interestingly, is that she's also got severe peripheral arterial disease, as most of our patients, as you know, who have severe coronary disease. Some of them do, but she has carotid, subclavian, as well as lower extremity disease, for which we're managing her medically, and we stented her subclavian prior to her coronary. So you will see the subclavian stent in some of her for some of her angiograms. So I'm going to have Dr. Waller just go over the angiographic findings. Jose?
Okay. Normally we
Wait, let me start with the first one.
we start describing the arch.
Hold on, guys. I'm just going to go to the first picture here. Okay, so it's a groin shot. Sorry about that. Here we go.
That's
Ready?
okay.
Plus, plus. Ready? There you go.
Okay, we see here our first shot. We're looking at the aortic arch. We divide the arch into three types, type 1, type 2, and type 3. It's based upon the angulation at which the innominate or brachiocephalic artery comes out of the aortic arch. This is actually a type 2 arch. That means that the innominate artery is coming somewhere between the outer curvature of the aorta, of the aortic arch, and the inner curvature of the aortic arch. Next picture.
Next, please.
So this is a shot of the right common carotid, and you see the bifurcation of the internal carotid and left and right external carotid. There's perhaps 20% stenosis in the right internal carotid artery. Next picture. This is cerebral views. This is a AP cranial view. You see that the internal carotid bifurcates into anterior cerebral and middle cerebral. We see a glimpse of collateral flow into the other hemisphere through the anterior communicating artery as well. Next picture. This is a lateral view where you also see the anterior cerebral and middle cerebral artery.
And very important that you see that the angiogram waits until the very delayed phase, and this is customary. You see now the veins coming in, and it's very important to observe that none of the arteries may be coming in at a very late. That would indicate that maybe there is a subtotal occlusion somewhere in some of the branches and they feel very late. So that's the reason why we prolong this angiography in order to include the vein phase as well. And not so much for the veins, but just in case some of the arteries show up late. That obviously, that's very important to repeat those things after the procedure.
Correct, and we don't see any evidence of AV malformation or any other vascular anomaly. Next picture. Next one. Next.
So this is, I just want to show this. So what we did here was we took an angiogram, which we failed to see. What we did was on the roadmap, we took a picture of the left carotid artery. And then we were able to identify the left internal and external. It's very important because what we use here, along with other systems, is the SlipCat system from Cook. We find it to be very effective in being able to track it up very difficult anatomies. This anatomy is moderately difficult, not very difficult. So what we did here was we actually used a stiff angle glide wire to steer into the external carotid artery. And then what we did was we placed this catheter in the external carotid artery. Next, please. Now this is the Cook slip catheter. This is a JB1. Using the catheter and the stiff Amplat super stiff with the soft tip. It's a 3 centimeter tip that's soft. We tracked our shuttle sheath over this particular lesion. Now, obviously, we're working with 2 screens, so we know exactly where the common external carotid bifurcation is. So we're taking it reasonably there. Next, please. Then what we did was we walked it out. We had the patient take deep breaths, and that's what's very important. So you have to have the patient take a couple of deep breaths. Okay, the deep breaths will help you know whether or not the catheter is going to migrate down or not. And how we do it is we first walk the slip catheter out, or whatever our support catheter is in the external carotid out, have the patient take a deep breath, then we slowly pull the wire back while the patient is taking a deep breath so that you clearly know exactly what's happening in terms of whether that catheter is going to move or not. So now when the wire came back, and now that we've got it, as you can see in this view, a good distance away from the carotid, but clearly with plenty of support. And you can even have her take a deep breath. Señora, show me down. Señora, respira profundo, por favor. You can see she take the down, respira normal. You can see as she breathes, the catheter moves up and down, and that's a very important part for all of you out there who are just getting started with this particular thing. So because a lot of times the catheter tends to migrate, and it's important, and you don't have the luxury of the Gore system where you have the ability to actually hold on to it with a balloon. So then, go minus please. Then we went ahead and did cerebral as well as internal carotid minus please. We did 2 views of the carotid, which I think is standard. You saw the other one. You can see here it's a very tight focal lesion, okay? It's right at the internal carotid ostium, not involving the external carotid, and really not involving anything else. So you've got a very nice landing zone, and when you take a picture like this, you really want to look at the landing zones. Now, if you have a very tortuous distal internal carotid artery, because at this stage, you're actually preparing for what you're going to do. If you have a very tortuous distal external carotid artery and you have a lot of curves, that may not be a great case for distal protection. What's my ACT, guys? So therefore, you definitely want to make sure that you decide what system you're going to do, and that's why we always do diagnostics prior to doing this particular thing. If it was an extremely curvaceous or tortuous or calcific air lesion, at that stage we may opt to use proximal protection with the Gore device, although it's on back order in that particular lesion. So here, it's not very tortuous, as you can see, and you can see you have a clear landing zone. So now my team and I, including our fellow, is looking at where we're going to land this filter. Now, where you want to land this filter is very, very simple. You want to land it distal enough from your lesion, and you want to pick the straightest segment possible. So here you have a nice straight segment here, just below the petrous portion of the carotid, and plenty of room between that and our internal carotid lesion. Next, please.
Exactly right. That what's the most important job in the diagnostic angiogram to select where you're going to land your filter, in order, first of all, to be able to deliver it easily, and second of all, to also have a stable position, so you eliminate the possibility to inadvertently the filter being entangled with a stent in some ways, and later on have problems in retrieving it. So you have to be further away and somewhat stable. I think this is actually an ideal case. You see that between 1 and 3 o'clock, essentially, there is a little bit of there's a curve right after the bifurcation, and following that curve, there is quite a bit of a straight segment that is would greatly accommodate the filter. Very nice.
And at this stage also, George, what we do is as you know, what you and I do is we go ahead and size our filter. And this particular area, we were in between a 6 and a 7, and we decided to go with a 7. Now, ideally speaking, you can measure this. I mean, we have a measuring ball. You know, sometimes we get CT measurements, we get different measurements. But here, having done enough of these, we figure that here a 7 should be plenty. So we're going to go with a 7mm filter. Then we took our intracerebral shots here, and as you can see here, the anterior cerebral, middle cerebral, filling very well. Next, please. And again, we went ahead and did an AP view or a Towns view, and you can see here again, very good filling. It's very, very important for the audience to know, and I know a lot of people out there want to do carotids because it's again coming back to life. Go ahead, follow discipline, and make sure that you have your pre and your post to make sure you see what's going on. Number 2, so you've identified your anatomy pre. Number 2, what I also want you to remember is the ACT. We do everything on heparin, and our ACT is now 303. Obviously, Dr. Rubin's done a lot of work with Angiomax and Lennoxil, and I know people do it on that, but we're very comfortable with heparin, and we go ahead and use heparin for most of our things. Our current ACT is 303. So we've been pretty good, and just finished, so I'm very comfortable. And what we're going to do now is we're going to go ahead and wire. And how we usually wire is we're going to go with what's called as a roadmap image.
So may I ask you, PK, what kind of filter? Let's talk a little bit about selection of filters. What kind of filter you want to use? I know there are a few filters around. You have there is a nav system, there is the spider, there is the more classic filter wire. Which one of the three would you use in this one?
Well, you know, that's a great question. You know, we chose to go with the EV3 filter here. Can you go more forward, Faith? We could have actually used any one of the filters here. We could have used the NAV6. We could have used the AccuNet. We could have used the filter wire, and we chose to use the EV3 filter.
So the spider filter is
spider filter.
the advantage of that versus the other ones is you can use any wire you want to any 0.014 wire to navigate the lesion. I think that's probably important here because the lesion is very tight as well as comes of an angulation. So you can use a run through or a BMW or any other wire you want, and then just over that wire deliver the very low profile filter. So actually it is, I think, a very appropriate choice here.
Right, so what we just chose one view. We know this lesion is tight. We have non-invasive workup. We know it's a hot lesion. We know all these things. So we're going to go with a very atraumatic wire, like you said. We're going with the BMW. We don't think we're going to need a lot of support here in order to be able to move this across this lesion. So we're very anal. We go very slowly on the fluorofade. And you can see here, just try to, without much twiggling of the wire across that lesion, direct it in. And then we want to get to this segment right about here and stop there. I don't want to be in the brain with that particular wire or anywhere close. I'm close there. But this area is a reasonable area because I'll show you what we're going to do. Now Dr. Wiley is going to load the filter. We picked a 7mm filter. The BMW is across. And the EV3 filter, as you know, is nice because you can use any wire that you want. So this has been flushed and prepared, and you can follow the usual instructions to flush and prepare it. It's not that difficult. But the clear thing is he's going to deflect that hole for me to be able to...
Yeah, so you see there is a green segment. This is where this the BMW wire is going to go. And then after that green segment, the wire is going to come out. That you see that after bending and then in the white segment that follows, that's where the filter is. So once we deliver this monorail system, we're going to retrieve the wire and then just push the filter forward through the green segment.
Right. So now we've got the filter in. Dr. Wiley's given me a nice rail. You know, we all three of us, you, me, and him, always exchange and work well together. So we're just going to go ahead and deliver this up. You know, the two things you need to watch for is the ACT. So usually at this stage, I would go ahead and give another 500 of heparin. I'm just going to give another 500 of heparin now. And the reason being is that this can take a little while with the wire exchanges and things like that. So I'm going to go ahead. I'm at 303. A little 500 will make her stay over 300 for me.
Yeah.
Just going to go across the lesion.
You see how very easy this goes. A very nice delivery.
I'm just going to advance this just to that spot there. Maybe a little bit forward.
Yeah, maybe a little bit more. If
but
you
again,
could
it's
take
not
that
making
curve
that
would
bend.
be good.
As I said, it's not making that bend. So
I wouldn't force it because
Yeah.
you got to push the thing anyhow.
Right, and we have plenty of landing zone here, George.
Yeah.
And I think this is a good area, and this shows a nice example. I was way up there, and obviously it did not want to. I'd like to have my wire up there to give me a little bit of support. It may or may not get up there, but we'll see. But right now, the filter is going forward. You can see it track very nicely, and you can see it here as it comes forward. Let's just see how this wire behaves. There it goes. Makes a nice little turn for me. And I think
great.
right here, I'm going to just deploy it.
Yeah.
You know, I'm very there. Jump forward like I wanted it to, and right there, we'll deploy it. Perfect. So now I've got the wire in the nice area. I've got my filter seated very well. I think everybody would be very happy with this particular way of doing it. And now I'm going to fix it. Obviously, the key now is teamwork and a lot of, you know, work together. So what we're very careful. We, you know, obviously, as everyone should be, we work closely, and we're just going to walk this out a little bit, and it's out. Now I got the wire. Let's go. And we're going to take this out. And we're going to break the wire at the level of where it should be broken.
So there is a transition of this wire, changes color in fact, and then you can just snap the two and just bend the two, and then it just becomes a monorail. Becomes a 190 length as opposed to a 300. It's much simpler. Jose, just bend them together. Once they go to 10-degree angle, it's going to snap.
I got it. Yeah. Okay. So we broke the wire to get rid of it. As you can see, sometimes it can be a little bit of a challenge. But now you know, we're going to make sure that our filter is in a good spot, and our filter is in a very good spot right there. So I'm going to go ahead now and go with our balloon. And Dr. Wiley's going to go with the balloon. Now, what we do is we give glycopyrrolate. Now, glycopyrrolate, you can give obviously atropine, you can give glycopyrrolate, you can give whatever it is in order to be able to increase the heart rate. We're going to go ahead and give glycopyrrolate. at this stage to increase the heart rate. So he's going to go ahead and give glycopyrrolate, and you're going to wait for the heart rate to go up.
Yeah, the supposed difference between glycopyrrolate and atropine, they have the exact same action in the autonomic nervous system, except that glycopyrrolate doesn't have any central activity in the brain and confusion, etc. Other properties that sometimes people with getting atropine have. But I think that's a good. I think pharmacologically, for this reason, it's a superior agent because we really need it for the hemodynamic response.
So obviously, when we took this out, we had a little trouble with the wire. I think they bent the wire a little bit. So we're going to try to get it in. If we need to retrieve the filter, we will. But
if you have problems now, might as well retrieve it, PK, because the stent might have a problem later, and that's. If you want to change a filter, may change it now.
Well, I think you just have to work with a, what is it called? This is something also that can happen, and I think you have to be very cognizant of the fact that, you don't want anything to happen, but Dr. Wiley is able to get it in. But I think, why can't you straighten it with a mosquito?
Well, I'll get it in right after. I think I do. Just to fix. No. Give me the mosquito.
We're going to straighten it with a mosquito, and then we're going to go forward. But while we're talking here, we still got plenty of time. What we're going to do is, if necessary, we will retrieve it. I think it's important, if necessary, you do need to retrieve it. You retrieve it and put another filter in, because I think these are the kind of cases where you want to make sure that you have good apposition of the filter.
Yeah.
You don't have too much jerking around, so on and so forth.
Let's talk a little bit, PK, now we have the time. This patient is maybe the exception, already had a coronary intervention, already been on Plavix, etc. But if someone is not, then we tend to give a loading dose before the beginning of the procedure, 300 or 600 milligrams of Plavix by mouth, in case patient was not on any clopidogrel beforehand, because we're going to have a dual antiplatelet therapy before the beginning of the procedure.
Right. So usually what we do is we go ahead and give what's it called, a loading dose, as you did say in this particular patients, to try and go ahead and do it. Usually our patients are on both aspirin and Plavix prior to coming in, and a lot of times they have been. What happened now?
I'm getting the other balloon.
We're getting a new balloon. Have been what's it called, preloaded. You can see here, if you show the hemodynamics, the heart rate has gone up to 96, and we are now ready to go up with the balloon. Unfortunately, we had a little technical issue at this stage. So if we need to go ahead and retrieve, we'll re-give the glycopyrrolate or give atropine if necessary and go ahead.
We should be okay.
It looks like Dr. Wiley was able to straighten it out. So if not, I'm not going to hesitate here. I'm going to go ahead and do it. The second thing, George, what we always watch for is hypotension, as you know very well. And what we do is we go ahead and we'll make sure that we have neosynephrine ready. So we'd like to maintain our blood pressures around 140 to 150. This is where she's been.
You have that.
Yep, I'm on. So you have the wire. Yeah. So again, we're talking, we're communicating, we're making sure that who has the wire, who's doing everything. No te muevas, señora. So we're going to go forward here. So as you can see, we're going forward, and now I've got the wire. I've got both. So we're going to go with this across the lesion.
So this is usually a 4040 or 4030 balloon that we use.
Actually,
both can fit this case.
We went with a 4020, George. In this particular case, it's a short lesion. We're going to go with a 4020 here, and you can see when the balloon comes out, it's probably going to be just right. And you can see it's just about right there. So we're going to take a little bit of dye. Our fellow Dr. Ali is going to give a little bit of dye here in a second. And then we're going to go right up. Just come off the fluorophane. Just a little bit of a, no, hand injections, yeah. So we're going to go ahead and just give a hand injection. Go ahead. Good. Yeah. So you can see here, we're very well placed across it. Now is when you do your checkpoint, okay? You tell your nurse we're going to go up with the balloon. You go ahead, look at your heart rate. Heart rate's 100. You look at your blood pressure. Blood pressure, good. Go up.
So are you using a coronary balloon for this one? What kind of balloon are you using?
It is a coronary balloon. We're going to go up to nominal, as you can see, down. So he went up to nominal, which is 8, all right, in this balloon, guys? 8 or 10, I forget.
8.
It is 8. It's 6, actually, so it probably went up to 6. So we went down. You can see now the blood pressure automatically comes down. So the blood pressure went from 160 to now 120, and Paul is ready with the neosynephrine. And now what we're doing is we're actually waiting for the air to come out of the balloon, for the dye to come out of the balloon. And we know that. Can you show my hand, guys? We know that because the bubbles will start moving in our indeflation device, our inflation device. So the bubbles are still moving at this stage. And the reason we do this is because the wings of the balloon, you don't want it to actually scrape the carotid as you come down. So we want that balloon to come all the way down, and now once it stopped moving, theoretically it's come all the way down. The filter is in a perfect position, so now we're just gonna go ahead and pull it back slowly, keeping our eye on the filter, you know, and we're gonna come back slowly, okay? And now, what we're gonna do is watching our pressure the whole time. The blood pressure has now come to 110, so we're gonna give one of Neo to keep it a little bit higher. So at this stage, everything is going really, really well. Wait, look, I got it.
Great. So now we have to start thinking about a stent. Obviously, we have the taper stents. We have also other non-taper stents that are self-expanding in nature. All of them, they can easily adapt to the maybe about a 6 or 7 millimeter diameter of the internal carotid and something like 10 millimeter diameter of the common carotid and create a nice funnel. And we also have to decide between a 30 and a 40 millimeter long stent. As we saw, even a 20 millimeter balloon it was used exceptionally here because the lesion was very short and actually was very stable. If the lesion was any longer than this one, is extremely focal lesion, a longer balloon would be preferable, because what you don't want is to have the balloon moving up and down during the inflation, the so-called watermelon seed. So you want to absolutely avoid that.
Exactly. So what we did here now is we've chosen, what have we chosen? 10-730, right? Right, it's a tapered stent, so we're going to open that stent now. Go ahead, guys. And
so why are we using a little bit longer stent is a question, and we can use, I'm sure, a 20.
We could use a 20, George.
But the answer here is that we don't want to spend a lot of time.
Exactly.
And it doesn't really matter as far as there's no risk of restenosis in relation to the stent length. So what you don't want to do is you want to fall short and then risk to have to put a second stent, and you don't cover the lesion proximally or you don't cover the lesion distally. And as you saw, there's quite a bit of respiratory variation, let alone that these stents move a little bit when you start releasing them. So for all these reasons, you want to kind of make your procedure simple and swift as much as possible. So a 20 balloon was very stable, so obviously a 30 stent is going to cover the lesion extremely well, and we're going to see how that goes.
So we're going to go with the stent here. Again, we're working very carefully together. We're going to lose pressure as we go in this system, but we can inject a little bit. So now the important thing is in placing the stent, you want to make sure you don't go too forward. A little bit of dye, guys. Okay, so you don't want to go too forward here. So you can see that's probably pretty good right there, George.
And even if it jumps a little bit, it's good.
Right.
Because
so
they tend to jump forward, so I think we're good. But
I'm just going to have Dr. Wiley deploy the stent without allowing to go forward. I'm just holding the wire for him, and we're going to just make sure.
And what kind of stent is this?
This is an EB3 10730. It's a Protege, I believe.
Protege. It's a Protege 10730. And again,
so we're just going to puff out. Okay, good. That's perfect.
10 is the common carotid. 7 is for the internal carotid, and the 30 is a length.
So
and
George,
as you
he
see, started already.
He just flared it, and now he's going to go ahead forward. Okay, good, and down.
I
so
think
now it's well deployed.
I think it became perfectly because it's exactly centered.
Exactly. And so I was a little worried about that bend. So now I'm going to just walk this out. We're waiting for the pressure because it's going to be damped at this stage because we've got our device in.
So the more important thing again to everyone is this is why the filter had to be further up, because with respiratory variation, if the filter is too close to the stand, you may entangle the it may get entangled with the distal part of the stand, which obviously has nothing to do with here because the filter is way above, which is an ideal placement. So this is what you need to watch for.
Yeah, so now we're out with this. We're going to have Ziad prep up. We're going to give another one of Neo. Go ahead, prep up, Z. So we're going to go ahead and have him prep up. Okay, pull back all the blood. So we want to make sure that there's no air anywhere in the system. And then we're going to come forward now.
George, notice that the patient is completely awake. No sedation has been given because we'll be doing neurological examinations throughout the case and at the end.
So now the pressure is up. We got it down to, it was down to 110. We gave another one of Neo. And now we're going to go ahead and deploy the stent. Actually, we deploy the stent. We're going to post-still. Now, George, as you know, the work done by Dr. Rubin at Lenox Hill has shown that this is the area where we get the most hits in transcranial Doppler in terms of embolic hits. So this is the area where a lot of times I think we should spend a minute on deciding who we should post-dilate and who we shouldn't. As far as our protocol here, if it looks really, really good, we normally won't post-dilate. But in this particular lesion, there is a waste. No te mueva, señora. There is a waste, and we're just going to go with a 5 and just get the self-expanding stent going. The other reason to post-dilate in a closed-cell stent is that sometimes capture of the filter may be difficult. And this is an area where clearly, tacking up the stent struts with a post-dill balloon may be reasonable. So my eye's on the pressure, and the pressure clearly shows that we're okay, and the heart rate is also good. And you can see here that this actually is having trouble going up, which again makes me a little worried about how hard it's going to be to get that filter out. But we're going to go ahead.
You see how important, how tight the lesion is on the lateral side of the stent. There is a compression. There's about a 50% residual. Very appropriate to dilate it. Yeah. And you see how the dilation occurred again. Essentially the whole lesion was displaced a little bit because it's a very hard plaque. It's not really a hard calcified plaque, fibrocalcific plaque with clefts there that we're trying to compress. An excellent result. You see how it went down to about maybe a 20 or 30% residual, which is a very, very acceptable and great for this type of procedure. The biggest lesson I want to offer in this situation is that you're not looking for a coronary stent-like result type of outcome here. You're not looking for a 0% residual or even a minus 5% residual with overexpansion of the stent. You're ready to accept a 10, 20, or 30% residual of the stenosis once you feel that the stent is appropriately covered the entire lesion and it's well expanded. And I think the most classic example is this one, that we're clearly accepting a 20% residual as an excellent result because, again, we don't want to be more aggressive with the post-dilation, and we don't want to cause unnecessary hits towards the brain. And watch the filter. Watch the filter. Yeah. Watch the filter.
Yeah, we saw that, George. Thank you.
And again, this is that's why you have to do all these things. So always on the fluoro, because when the balloon, the post-dilation balloon comes out of the TUI, there may be some respiratory variation as well. There's a small movement of the filter in and out, but these filters are very flimsy. There's no issue of trauma or anything.
All right, George, we had an unfortunate little movement of the filter there, and we'll come forward, please. Slow. So we're just having a little trouble prepping up, making sure that there's no bubbles or anything. I just want to make sure that there's no issues here. So I'm just making sure I pull back 10 cc's of blood, and then I'm going to go ahead and flush forward so we have nothing. And now we're going to go ahead and take a picture before we remove our system. Okay? Okay, give two of Neo, guys. Blood pressure came down. Blood pressure came down. Yeah, she's doing great. I just want to make sure that we have everything done here. And the reason we take a picture, George, is to make sure whether or not we have any area of dissection, spasm, whatever it may be. And it's really a good habit to be able to take the picture prior to removing your filter. It also tells you what's going on distally. I wouldn't necessarily do intracranial shots. I would clearly take a picture of my stent. I would take a picture of my proximal area of my stent. My eyes will look distally, look at the area of the filter. Sometimes these filters, especially these filter wires, tend to cause a little bit of spasm, a little bit of, whatever it may be, beading appearance, irritation of the distal internal carotid. So therefore, you clearly want to be able to watch exactly, what's going on prior to you taking it. Rarely, you can have a dissection. It's actually extremely rare. But most of the time, when you have these type of spasms and other things, what you can do is just treat it the way you would do a coronary spasm. Her heart rate's still rock stable. She's fine. She's, talking to our nurse here. Everything is good. So we're just going to take one picture. Señora, no te respirar. You can see here on injection here, we're able to see that the filter is still in a nice spot. And you can see here that it's clearly open well.
Excellent flow.
And the lesion looks good right now, and the flow is really good.
Excellent flow. No need for anything distal thing. Yeah, tell me.
I am a little concerned about whether this is going to be retrieving easily or not. So let's see. Can I have the retrieval device here?
So the way to the retrieval device of this filter is very simple. It's just the opposite. It's just the other end of the delivery device. As we said, there was a green on one end, then was
Can you show the
the
audience
white,
green and the blue?
and now we have the other end, which is the blue. So therefore, we delivered it via the green. We push it out via the green, and now we're gonna just flip it the other way, and we're gonna use a blue in order to go over it.
So you go in with the green, as George said, and you retrieve with the blue.
So the important thing here is not to throw it away. So it's important that whoever you're working with is going to preserve this particular device to capture it. Obviously, EV3 would like you to throw it away so they can open one new one because they don't make any extras. But same time, I don't know why they don't. It's one of those things, George, that it would almost be intuitive for the company to say, hey, we've made an extra couple of retrieval devices in case, retrieval systems in case the one hits the ground. But they're very smart. They don't do that. But all jokes aside, her heart rate is extremely good. Her blood pressure is extremely good. And now we're going to go in. I'm telling you, I'm real concerned because the way that balloon came out, the trouble that Dr. Wiley had with retrieving it.
It's going to be a good test to the capabilities and the flexibility of the retrieval system,
Right. Wow.
which apparently is stellar.
I am totally wrong. Now here, what I'm going to do is I'm going to fix the wire and I'm going to push my device. So I'm fixing the wire, I'm pushing the device, capturing the filter.
That's great.
Okay, and it's very difficult at this stage right here. So I'm again going to continue to fix and pull, and there it is. So now I got the filter completely.
Good.
So now in one full swoop, I'm going to go ahead and remove the whole thing out, okay, holding the wire and the device. Now I get a 30 cc syringe. We get a 30 cc syringe. Maybe we're a little bit of overkill here. A lot of people may not accept it, but what we do is we get a 30 cc syringe, and we go ahead and withdraw 30 cc's of blood. And that's why we make sure that we're not vampires here, but make sure that there's no clots, no debris, no anything that extruded from the filter as we pulled it through the through the system.
Exactly. The back bleed the system is very important
Yep.
to have the
Then what we'll do is Dr. Wiley's going to prep up. I'm going to take my hands off. So he's going to prep up the whole system, and he's going to make sure he bleeds back at the level of the TUI. Again, the same things we do in the coronary, but I think here the organ is so. One more, Neil, please. The organ is so unforgiving.
Can we show the blood pressure a little bit just
Yes,
to get
we
a
do.
glimpse on the hemodynamics?
Yep.
Can we just show the?
You can
so,
see she's dropping down.
You see, it's between 100 and 120 is pretty good now. That's. I mean, it started at 180, so it's clearly down. We support it with Neo, but that's where you're going to hold your defense in between 100 and 120. If you can titrate that, if needed, with boluses or with drip of Neo for some time,
Exactly.
that is very acceptable.
And I think that's a
standard.
great point that you make, George. What we're going to do here, just take some pictures. We got a little extra time, so you and I can spend some time while they take everything out. So we're just going to take a picture. Señora, no te respirar. So you can see here, my eyes look at the stent, my eyes look proximal to the stent, and they look at the distal area where the filter was, and we have nothing going on, and you can already see the intracerebral vessels are filling. So now go lateral, guys. This is like a partial lateral, but not a true lateral. Watch the IV pole. So you want to take it in a bunch of different views here to really look at the stent in different views. That calcium that you see in this particular vessel, you can see it's eccentric. Because here you can see that you can see, no, you just need to drop the table. You can see that the stent looks like it's not expanded in one view, and it is expanded in the other view. And that's very important for, can I see the stent, please? I think that's very important for those of you who are starting out, not to expect a coronary type result. The coronary type result will clearly get you in trouble because you don't want to either further embolize or you can also perforate technically, especially since the lady had a little bit of pain. No respira, señora. So we're going to go ahead and inject again. And you can see here in this view, it certainly does look very nice and looks expanded. Now let's go to the brain views. So this is why it's important to have both pre and post to the brain. So clearly now we've got our pre-pictures, and we'll go ahead and compare all our vessels in the post in the brain. And so we just need Dr. Wiley to line it up perfectly, which she's very good at, and we'll line up the earlobes. The way to do this is to make sure that you line up the earlobes as well as the orbital ridges. And Dr. Wiley's trying his best here. It's hard because she's moved her head a little bit. So we're just going to make a little bit of adjustments. And a good way to kind of see is if you can see right through the earlobes, and you're going to be able to see it. Raise the table, please. There you go.
We
Okay.
got it.
Well, a little too much.
A little bit too much raise.
There you go.
We got it here.
So this is probably reasonable enough. No mueve, senora. So we're going to inject here. Got good flow. Everything looks really
Yes.
good.
And then we're staying again to
Yep.
see that the veins fill. There is no
Sounds good.
filling of any artery in the late phase, which is a very, very important. Great. And do you take a lateral picture of the stent? Or
We did,
did.
George.
You did, okay.
We did a lateral picture. We did a partial, like AP lateral kind of picture. Now we're going to do a Towns view here.
Great.
And then what we're going to do is,
Straighten the head, please.
Straighten the head, please.
I was looking for a question that was submitted here, though that's why I missed that view. Anyhow, I want to remind everyone who's on the webcast to just email us any questions at the email address info@peripheраlinterventions.org. Peripheраlinterventions.org. Info@peripheраlinterventions.org.
So George, you can see in the Towns view what Dr. Wiley did was he lined up the orbital ridge right there with the Peters portion of the temporal bone, and you can see here very, very clearly we magged up one more to be able to see no mueva, senora, and he's going to inject, and as he injects, we really want to see that everything fills, everything looks really good. Obviously, you know, I think anybody who does carotid stenting should take a little time, review the intracerebral literature, anatomy, and know the angiographic findings, and I'm going to have Jose go over some of the major arteries so we have some time here. We're also going to take one AP shot, okay? Senora, respira profundo.
So this is a great case,
Aguanta la
and
respiración.
the question we
Aguanta.
have, PK,
Aguanta.
is regarding the use of silostazole
Perfect.
as a possible triple therapy.
Respira normal.
What is your views about that? There's certainly some literature that silostazole may reduce restenosis in bare metal coronary stents.
Yep.
What is your views about the carotid or the peripheral circulation for silostazole?
Well, you know, let's address the carotid first, George. As you illustrated beautifully earlier, you know, the sizing of the stent, the length of the stent, all these things really don't have much to do with the restenosis. I mean, the major issue with carotids is the procedural stroke that's involved, as was shown by the CRUSH trial, even though most of those strokes, as we know, have no, you know, consequence in terms of, you know, prolonged symptoms for the patient. As far as this loss of restenosis is concerned, I mean, our concern is just to follow these patients, and that's what I wanted to really spend a little time. You know, how we follow these patients, as Dr. Wiley will take this out, I'll just step to the side. Actually, let's just illustrate how to take this out.
Let me do a quick.
So before that, what we're going to do is
Aprieta mi mano derecha.
he's going to check her, and what I want to say is, as far as our protocol is concerned, we follow 1 month, 3 months, 6 months, and a year. We go ahead and do obviously ultrasounds to make sure that they don't restenose. As far as therapy, if they're only on carotid stents, we usually continue aspirin and Plavix, but we stop Plavix in a month. Aspirin for life is what we usually do. But most of our patients are on both aspirin, Plavix, and Platol. I mean aspirin and Plavix for coronary issues. So therefore, they usually get dual therapy for the duration of their coronary stent. Number two, as far as the role of Platol, as for carotid stenting, I myself have never used it. I don't know if you have, because I think the restenosis rates are so low, and you do have a slight increased bleeding risk because of the antiplatelet therapy of silostazole. As far as the peripheral circulation is concerned, we have used it, and we have multiple patients on aspirin, Plavix, and silostazole in this particular kind of situation.
And how long would you use the aspirin and Plavix or the aspirin and Plavix and silostazole in periphery or in carotid?
You know, it's such a difficult question to answer. You know, as you know that, you know, it's one of those things when you are faced with recurrent restenosis, when you have issues. In the peripheral, you know, because of that coronary data that we have available, we have gone ahead and used it in patients liberally when it does start. But there are a lot of nuisance complaints that the patients have. You know, they do have obviously GI bloating, headaches, so on and so forth. So it's limited on the drug. Patients who've tolerated well, we've continued for the duration because I do believe that silostazole does help with their claudication. But the reason I started is really more for their claudication. If they still have some residual claudication because of distal disease, whatever it may be, after opening up the SFA or the iliac. I've never really used it personally for restenosis in the peripheral, and as you know, the data is very sparse. Neo-drip, guys, let's titrate it.
Now let me ask you that what is the minimum obligatory duration of Plavix after a carotid or a peripheral stent?
At 30 days.
There you go. That's another pointed question. It's very clear. It's good to continue. If you think there are other reasons, other risks, it may help, but the absolute minimum is a 1 month. That is what is accepted. Now, because a question regarding silostazole was actually coming from Japan, I want to say that in the Asian population, the use of silostazole has had more success because there tends to be more resistance to clopidogrel action due to enzymatic genotyping of in the Asian, the Asian population. So therefore, particularly in the geographic areas, one may consider genotype testing for clopidogrel or more liberal use of the aspirin clopidogrel silostazole type of therapy because of these specifics of the Asian population.
Now, George, I just want to go over how we remove this. If you can just go back to the screen. Dr. Wiley has taken a stiff wire, a superco wire. Now, you can obviously use an angle glide. You could a stiff angle glide, whatever it may be. And we go ahead and place it inside the common carotid. Now, what he's going to do is I'm going to hold pressure on the groin so the lady doesn't have pain. And what he's going to do is not advance the wire, but keep the wire there. Flora, guys? So he's going to keep the wire there.
We can decrease a little bit why don't we decrease a little bit the magnification so we can see the entire arch and the curve of the wire. That would be great.
So there you go. So now what Dr. Wiley is going to do is just walk it out without advancing the wire. And when he walks it out, what you don't want is that whip in the arch in these type 2 arches. So he's going to walk it out very slowly. You can also put a dilator if you want. But we do it mostly with stiff wires because you know there's arch calcification. And again, this will also prevent something ruining your great procedure that you're done. Yeah. So now he's out in the arch. Now he's going to pull the soft part. Now he's going to advance the wire. And now I'm holding negative on the groin. Lower than Neo, guys. It's very high. We're going to go ahead and pull negative on the groin as he walks out. So I'm holding the groin so that the lady doesn't have pain. Respira, senora. Respira. So I'm holding the groin so that she does not have any pain. Because sometimes when you pull this hard, it'll stretch the groin and the lady will scream in pain, or whoever it is will scream in pain. So once it comes out, we're obviously going to get a 6.5 sheath ready, and I'm going to bleed it profusely out. Once I let all the blood out to prevent any embolization, I'm just holding pressure. We're going to go with a 6.5 French sheath. What we do at this stage, George, is that we watch the blood pressure. If we'd like to keep the blood pressure below 150, but above 110. So that's how it's a very stringent goal. So they usually need an A-line. And you saw there the blood pressure shot up to 170, and those of you who were at our conference know what Dr. Woolley was saying about keeping that blood pressure a little bit lower. So now we go ahead and now we're going to titrate the Neo, and that's going to help us. So at this stage, we're going to use the femoral sheath as an A-line, and we're going to watch it here for a few minutes. Most of our patients, as per protocol, do go to the floor, but there are the select patients who are hemodynamically unstable who need neosynephrine in order to maintain their blood pressure in a reasonable way. Flush it for me. Pull back.
Exactly. So the goal here would be to observe the patient for 5 or 10 minutes in the room. Let's see how the refractory the hypotension may be. And then decide whether you're going to close a groin, and if you close a groin in the room with an angiosyll or something like that, then you would perhaps entertain the possibility to put a radial A-line in case you're planning to send the patient to the for hemodynamic monitoring overnight. And again, let me also clarify that even if the patient goes to hemodynamic monitoring overnight because of the need for neosynephrine drip for some time, again, this doesn't mean that patient may not go home the next day.
Right.
Most of these people get better overnight, and in the morning they are able to ambulate and retrieve, have the A-line retrieved and able to depart the next day. This is the hypotension is not related to any blood loss or any volume loss or anything like that. It's primarily related to the baroreceptor stimulation of the carotid bulb, because essentially you're exerting, the stent exerts an outward pressure, or the balloon exerted an outward pressure, and as long as the body ultimately kind of accommodates a little bit to the new logistics around the pressurization of the carotid bulb, things will settle down. There have been actually scientific papers in reporting hypotension over a period of time, even including even after carotid endarterectomy procedures, again because of the surgical manipulation of the same area, And indeed, it's very interesting that some people may have a beneficial effect on their blood pressure control after such procedures, but indeed, the clinically important orthostatic hypotension and things like that just are pretty much an overnight phenomenon that resolve by the next day.
The other thing also, as Dr. Dengus pointed out, is one of the things is the arrhythmias or the pacemakers with symptomatic bradycardia. Same thing, exactly what he said. We've also had a couple of patients who have spent overnight in the CCU because of bradycardia in the 30s and low 30s. No one has ever required a pacemaker. No one has ever required even a temporary wire. We've watched them very, very carefully, but given them atropine as necessary, and they usually recovered within 24 hours. But as time is getting close, I just want to just reiterate a couple of points, just as take-home points. Number one is obviously patient selection. As far as carotid stenting, I think anybody who does a lot of stents will go over it over and over again. As Dr. Dengus said, preparing the patient, getting yourself prepared to go ahead and do carotid stenting is extremely important. So number one, you want to select the right patient. So the right patient means you need to look at the arch. Depending on the level of your experience, obviously you want to go with a type 1 arch versus a type 3 arch. So again, regardless of what arch it is, the preparation will help you to get the right equipment and the right hands into the room to help you. So first of all, obviously, I would advise all of you to do a CT angio or a diagnostic cerebral angiogram, a carotid cerebral angiogram in preparation for your patient. Obviously, in this patient, we had a CT, but I had to do the diagnostics again in order to illustrate to you what are the views and everything. But normally, we would have just gone right ahead and done our carotid stent without having to give the extra dye. So that's number one. Number two is to go ahead and get experience within the room. Create a carotid stent team. So we have a carotid stent team together, so comprised of 3 nurses, 2 techs, obviously multiple physicians, me, myself, Dr. Dengus, and Dr. Wiley. And also, we also have this team that's together, so we do it as a team. So the bottom line is the team bridge approach will go ahead and will win for you at the end in terms of your complications. Number 3, you want to make sure you go ahead and do all the prerequisite views. You want to do your aortogram, you want to do 2 views of your carotid, you want to do at least 2 views of your brain. If you need to do more views, you do more views. If you need to look at the vertebrals, you look at the vertebrals. Whatever it is that you need to do to be able to plan your procedure. Number 4 is while you're working, make sure that your ACT. Don't forget when you're so tied up within doing a case that you go ahead and lose track of basic things such as your ACT, your heart rate, your blood pressure. Number 5, train your post-op team. When the patient goes to the CCU, we have wonderful fellows here like Dr. Ali. We want to make sure that these patients are followed. So in the CCU or on the floor, the nurses are very aware and they have protocols in place to be able to call either the attending, the fellow, or the nurse practitioner to be able to help the patient out. Number 6, neurological evaluation. Make sure the patients are seen by neurology pre and post procedure. Obviously, the orders may be jumbled up, but the point is, it is a team-based approach. It's not bring the patient in, let's put it in, and let's go ahead and do the carotid. A lot of cardiologists get into trouble by doing it that way, but we're fortunate here because we have a very team-based approach. We also perform carotid stentings with our surgeons very closely, so we have a great collaborative effort here at Sinai, and I hope that you can develop that in your institution as well. So again, George, from the cath lab here, we've got exactly 5 minutes. I think we had a nice illustration of carotid stenting. I thank our team. I thank you. I thank those of you that logged in and those of you who will watch this as an archived presentation. I look forward to you joining us every month. And next month, we have a wonderful case of an a distal aortic occlusion that we will illustrate for you in July. And then hopefully we will continue to show you challenging cases, but more important than challenging, just educational cases where you can come in, watch us do what we do. Not that there's only one way of doing something, but at least you can learn or share with us your thoughts on how we do things and how that may help your practice.
Exactly.
George, thank you very much.
Thank you, PK. Congratulations for another excellent case selection and excellent case performance in a very didactic fashion. I'd like to remind everyone that the www.peripheраlinterventions.org is a website that hosts all these webcasts, even the archived ones, and we'll see everyone the same time, 8 a.m. Eastern Standard Time or 3 a.m. Greenwich, excuse me, or 8 and 5, 1 p.m. Greenwich Standard Time, I should say, for the July 25th webcast. See you all then for another great peripheral endovascular case then.